I will start with communication, and next I will go for the how to break a bad news. So why communication? First thing, why this topic? So first we have to talk evidence. Now this MMC, Maharashtra Medical IMA, and our medical team, they have specially mentioned that it is a core clinical skill. When we did the MBBS, there was no such communication training given to the students, but now it is given. It is in the syllables, and they say that it impacts the patient trust. Of course, it will reduce the medico-legal conflict which is happening, and it will definitely enhance the professional satisfaction. And this is Attitude Ethics ATCOM. It is a 50-page book which they undergraduate undergo training nowadays. So communication definitely matters. Now let's see what the communication means. So if I say I am communicating right now, there are different faculty working. These are the 4 quadrants working right now. So verbal communication, non-verbal also I am communicating, written communication or a formal communication. These are 4 parts. And out of this, which is you think is the most important when you counsel the patient in your OPD office? It is the non-verbal communication. How many of you agree with that? So 20%. I can prove you'll become 100% if I give you a demo right now. You want a demo or you want a video? It's your choice. Just a request, who has attended this demo before, don't attend now because you know already. So who has not attended the demo of communication? So those who have not attended, bring your right hand in front, make a ring, and quickly follow my instruction. Make a ring, quickly put it on your chin. Quickly put it on your chin. This is cheek. Chin is here. So what was it? It was the visual communication. It was not hearing. You are not listening to me. You are seeing me. So that was the visual communication. So this is how the communication matters for the patient. He visualizes. You are talking to him ki you has got acute kidney injury with all this jargon, medical jargon, and he is looking at your face. And he is trying to understand what you are telling. Now, why non-verbal communication matter? We understood. 60 to 70% of the communication is non-verbal. And this is true even for a comatose patient. Even if he is unconscious, he is listening. There is far amount of evidence, and in Indian cinema also there is evidence. I will show you.
आनंद बोलते हैं कि लव में ऐसे ही छूता है। सर्किट भी बोलता है कि अगर फीलिंग स्ट्रांग है ना तो बिना फोन की चिंगूर तक बात कर सकते हैं। अरे कोई सिग्नल दो ना आनंद, बोला ना आपको कोई लव शब्द नहीं होगा आनंद। करेक्ट, ऐसे ही लगता है अपन लव में पड़ने वाले। ए आनंद भाई, ए डॉक्टर इधर।
So you got it? So can you say what was the communication there? It was with the eyes. So he just said yes by blinking both eyes. So when you want to say, blink your both eyes if you are in meeting. Don't blink single eye, it is dangerous. It can be carry different meaning and you will be in trouble. You know that. So non-verbal communication is what patient perceives beyond words. So that is one. Are we using in clinical practice? Yes, we are using it. So pain assessment tool. If you see, we use this visual analog scale, how much the patient is in pain. So you can incorporate in practice. So this is all about visual. Right from childhood, our mother used to just say like this. Our teachers used to use non-verbal communication for the crowd. So non-verbal communication is very, very important to understand. What are the other features of non-verbal communication? Facial expression we learned. Eye contact is important. If you are not having eye contact with your patient, he will feel that you are not giving enough time to him. Then gestures, what gestures you are making? Okay, he is telling his story, you are picking out your phone. Just a minute, you continue. Yeah, what? Yeah, just a minute. So that is a very bad habit. You will not getting attended to your patient. This is a distractor. This should stop. Then what is your posture? How you are listening to the thing? How much close your body proximity to the person? What is the language and what is the physical appearance of a doctor has to be clean and shaved, and definitely it matters because you're not preparing for yourself, you're preparing for the other person to see you as and to have trust in you. So non-verbal gestures, these are the gestures is very important. In certain profession like surgeons, in OT they don't shout, give me scissor, give me scalpel, they just do the thing. Okay, I want this is scalpel, I want this is scissor. So non-verbal communication is so rampant in our medical practice, non-medical, and we should understand that. Now, how to avoid the negative non-verbal behaviors? So I told you, so have a eye contact with the person you are talking to. Arm crossed is a defensive posture where the person doesn't want to listen or he has some feeling which he is not comfortable. You have to make him comfortable. Standing near the door or is like you are about to leave and the patient is telling you the history or in rush, that should not happen. Checking watch or phone again is a negative non-verbal communication. What is a positive verbal communication? The person doesn't know the language, he doesn't know Hindi, he doesn't know Russian, but see, what a friendship. It is a perfect example of non-verbal communication. Gentle eye contact, hand gesture, look at the hand gesture, calm hand gesture, they are both enjoying, sitting at same level. So this is what with your patient you should have. So the language is not a barrier, it is the non-verbal thing, how you work. Now the second most important thing in which you already get training, if you are married you already got training of that. What is that? Listening. So listening is another very important part of training. So art of active listening is very important. That is the other concern. You don't listen to your wife actively, but you have to listen to your patient actively. So what are the components? Mindfulness, non-judgmental. If the patient is telling the story something, you let him finish. There was one study in CMC where they did in the OPD and the doctor stopped the patient in 11th second. He started just, I am feeling a little bit of burning sensation. Okay, and he just rushed to the diagnosis. Peptic ulcer disease, appendicitis, take this next patient. Wait a minute. He's not there for that. So you have to listen to complete story and to have avoid distraction, be reflective, clarify, give that time to the patient. So it is not the diagnosis there, it is the time you are giving. That's what Hippocrates also told. You cannot treat everything, but you can comfort the patient. That is what is the most successful OPD practitioner will do. He will give 20 minutes to the patient and he will be successful. This is what in history also that if you listen to the patient carefully, they will come up with the diagnosis. You don't have to give the diagnosis. They will tell you the diagnosis. So there are two models which have been, you are very good practitioner. I am just giving you what the science have given. There are two frameworks of practice. One is either you patient centered or the doctor centered. So on these two sides you are seeing, one is the patient perspective. So this patient came with a backache. What is going in your mind is whether it is infective, whether it is traumatic, whether I should do the scan, whether I should do the MRI. That is your concern. What is the patient concern? I have a backache. I came to the doctor because I cannot do my daily wages. I am a lifter. I lift the wages and I am getting my wages lost. So that is his concern. So look at what he is concerned about. So let him express that idea, concern, to empathize and get understanding about it. And then you intervene with, interlace with, and then make him in the shared decision making. And this is how you try to integrate the two framework of your patient, and then that is a patient sharing decision making. So that is most important in office practice, in ICU practice, everywhere, wherever you are doing, and you will have a 100% satisfaction, which no money or nothing else will give. Talk with your patient. You know so many different stories. Our boss shared so many stories. Look at the dopamine, look at the happiness he was having. It was not the money, it was the satisfaction which was speaking out. So that is important. Therapeutic touch, you should be careful. So somebody talked about religion. So of course be sure and give a light touch or shoulder when the patient is overwhelmed by emotion, that you have to see and you have to decide when to, where to, and respect the cultural boundaries. If it is important, then only you say. One video is running in social media, you are aware about that? Our chief minister of Bihar or somewhere is just pulling out, and that lady, so cultural background is not respecting, so at that level, so that communication is not good. So that is the therapeutic touch you should use properly. So key message is about non-verbal communication, verbal communication. If you understood these components and you understood the thing, then now you are ready to give the bad news. Now we will move to the second part, giving bad news. So what is the bad news? So everyone in life has to give bad news. In OPD, sometimes you get a patient report, he is underwent biopsy, he is your family physician, he comes with the biopsy report, you see, oh, this is invasive intraductal carcinoma of breast, stage 4. You don't read it out loudly to him and directly transmit the information. So you have to know this skill, how you are going to break that bad news to the patient. So it is about the serious diagnosis, about the poor prognosis in ICU, it is about patient having brain dead, or if the patient is really prognosis is bad, or the treatment is failed. So all these things you have to communicate with which alters the patient and relatives aspect in a very proper framed method. So like CPR is the guideline. So similarly there is guideline for breaking bad news. What are the challenges as a doctor we should expect? So there are 5 stages of grief. So if you give a bad news, first is, this cannot happen to me. What you are saying, see the report, see the pathological report, whether it's wrong. See, it cannot be me. I am the vegetarian person. I never smoked. I never had alcohol in life. I am religious. I pray twice a day. Whatever things. So that is the denial of the patient. So everyone has a denial. Then second stage will be anger. So during that period is a very important that we should remember we are human beings. We grown from the monkeys, they say, and we have think to ape like a mirror. So if the person is getting angry, and if you are also, you tend to get angry, that don't do that, do opposite of that. If the the person is raising the voice, you slow down, you even slow down the voice, and that environment will become down, that he will also cool down after. Give him time to vent off. So that anger is important. Third is a bargaining. He will start saying what can be done. Then depression and acceptance. So acceptance is a stage where you give him the therapeutic option and further. So these, you have to remember which stage your patient is. So in emergency department, this is very important. Emergency department faces a lot of this emotional from the relatives, political, and lot of pressure and lot of stress they are working. Actually, yesterday I was handling one stress workshop in Sassoon College, and all this EMS person were there, and there was very live debate about that. So they are facing lot this distress, time constraints, emotional burden, cultural literacy difference, and family dynamics. So they see lot of these challenges. What are the principles of effective communication? So I told you, you are already aware. So active listening, allowing the silence in between the two words, so that give him time to express his emotion. The emotions are something which you should use. You should not get overwhelmed by it. Respect the autonomy of the patient and dignity. So 7 C's they have mentioned, like in airport we go. So your plane is going to about, we listen very carefully, and there is no mistake, and the announcement is so clear, concise, correct, with confidence and with coherence. So that's clear information. That is what we should practice from aviation industry. When that girl comes, tell the oxygen thing will go down. You have to, every time they do the same thing. Why as a doctor we can't do that? We get bored by doing that. But we should do it. We should practice it. It's a profession. So be clear, concise, correct, confidence and coherence. Now coming to the end part, the protocol which is world over practice is the spikes protocol. This spikes protocol gives you the idea how to break the bad news. So first is the setting, then perception, invitation, knowledge, empathy, strategy. I'll just go one by one. So what is setting? The setting cannot be a corridor, setting cannot be a veranda, setting cannot be a other place. It has to be a session has to be in a place which is quiet. Even if it is your OPD, you have seen at the hotel we put down, do not disturb. Why can't you put that board, do not disturb? Because in between someone come and disturb. It is a life saving decision for that patient. It's a big decision, big day for that patient. So give him that much time. So put some tag. Nobody should disturb during that period. In that session, those people are inside. You have your water ready. You have your tissue, whatever emotions is shown. You should be prepared with all those things. Have a counsel, have a lady along with you, social worker if you want. So build that thing. Then you ask what the patient perceives about his condition. So what is his perception? In which stage of thing he is? Is in anger phase? Is denial phase? You try to judge that phase, and accordingly you go to your next step of invitation. How much you want to know? What is the thing? What do you understand by this report? And how is going to affect? If you are talking with next to kin, again same thing applies. Then when you are giving knowledge, this is the important part for a doctor. So we as a doctor, we should remove that level of doctor many times. If you remove, you are in much better condition to explain the patient, because we avoid using medical terms. Now there is a AI things are said, we can use smartly AI. You can show a picture of brain, you can show what is effect, you can show the people what is being done. So that is easy to make them understand how you give presentations. So that is the third step, to apply the knowledge. And then after you have given the information, you have given that the patient is suffering from brain tumor, the next step we have to slow down. Now you should see whether he's understood the problem. He become emotional after getting, somebody tells you have glioblastoma stage 4. So that will be a threat for him, and he will be in shock and freeze. So that is the time of silence. Just be silent during that period. Let him express the emotion. Give him a therapeutic touch and try to understand what his problem are, what his family, and that's how you give the third step. And that is what acknowledging the emotion. And last is the strategy. Next, if he wants, you tell him what best we can do. So one of my friends, our colleague, was diagnosed as a stage 4 glioblastoma, and he messaged me, I have 3 months left. I thought this must be a joke from him. And when I came in, he showed me the biopsy report and he took it very positively. And then the strategy was, with chemotherapy 3 months, without chemotherapy 4 months. He chose, I will not take any therapy. He died at home. So the choice was patient sharing decision. We cannot force him to take if the lifespan is not that much. So that is the shared decision making you have to sometimes give. Don't rush at the decision. These are the common mistakes. Don't use medical jargons. Give false reassurance. False reassurance by patient like honesty. So be honest with your but in the way the patient can understand, and avoiding the too much emotional drama in that. Be right to the thing. Then silence, as I told, validate the feeling. Avoid the arguments as far as possible. They will be in denial, they will be in anger. Try to listen their point of view and be in the present. That is mindfulness. So be in that present situation. One homework I will give you, I will not discuss here. 55-year-old lady diagnosed with cancer. This is a biopsy report come to you. How will you break bad news in your OPD? You can write it down. You can prepare a plan. If such patient come, what I am going to do. Ultimately, communication is a learning process. Goes on, and what you have to do is you edit that. What went well, what you could improve in that, and every time there is a scope of improvement, and what were the challenges, specific challenges pertaining to you. What are my challenges in ICU is different. What your challenge in OPD will be different. So you have to make a protocol, something like spikes. I am not saying just follow spikes. You made according to your local needs. So that is what we should start doing. And last and most important part, as Dr. Upendra also mentioned, self-care of doctor is very important. After such session, we think we are very great, but we are human beings. We work in ICU since last 20-25 years. We carry those emotions. So we are in emotional burden sometimes. So having a connection, having a enthusiastic leader like our leader. So you be in touch, do debriefing, and be mindful and be with peer support. So that is what I have to say. And the key take home: communication is a core skill. Structure will reduce the stress, and empathy will build the trust. Thank you very much.
Thank you, Anand sir. Any questions? I think we will be having some.